souls honoring Elohim's mandate. And now for today's message.
Well, hello. Welcome to SHEM Ministries, Souls Honoring Elohim's Mandate. And tonight is our SHEM Tonight. That is a spiritual, healthy, enlightening mandate ministry. And I am Dr. Anna Shaw Devlin. I am a family nurse practitioner. And I love love what I do. What do? I am an empty vessel that is willing to allow God to fill me up and use me for His glory. I allow Him to use everything about me, whatever gifts He has given me, not me myself, to be where I need to be at the appointed time He needs me to be, so that I can leave behind a piece of Him, walk into the midst of a crowd. And if I have to jump up and down for attention, just so people can hear me say, there is nothing impossible without God. It is worth it all. Am I willing to look crazy? Yes, I am. That is who I am. I love being free to be me. Glory be to God. And those of you who know me, you know I'm not joking. Well, welcome. Tonight is it will be the second part of the message from last week. What goes up must come down, part 2. But before we begin, let's give God all the honor, the glory, the thanks, and the praise for still being in the land of the living today. Every day there is a mass shooting. Unfortunately, there's an attack. There is an attack this past month on African American women, mothers, right before Mother's Day. What is God saying? We mothers have been through so much to raise our children the way God called us to. And unfortunately, there is an attack against us. But guess what? You will not win. Oh, the devil cannot win. I refuse to stop praying for the victory. I refuse to stop praying for God to speak to the heart and minds of these women. Heed the warning signs. I believe these women were victims of abuse long before their demise. And the situation that just happened in Louisiana How can a man kill all his children? Glory be to God. Father, what are we going to do? We must fight back. We must fight back in the spirit realm. The warfare is in the heavenlies. The warfare is the angels of God being dispatched. Glory be to God. He gives them rule over us. All we have to do is believe and exercise the rights that we have as children of God. And if the mothers did not believe in him or were so bound in their situations that they felt desolate and alone and that God left them, the devil is a liar. He promised he would never leave you nor forsake you. Did you stop calling on him because you endured so much for so long that you felt that he forgot you? Oh, Father, please, Jesus, send out a message, God, a beacon. Glory be to God. I think about these ships in the sea, lost, trying to find their way to shore. And there's the lighthouse and there's the beacon sending out a signal saying, here I am. Here's the shore. Here's the way to the shore. Just follow the light. Lord, I'm asking that you send your anointing on your angels to touch the heart and minds of women and even some men who are being abused, who are victims of domestic violence, Lord. And let them know that there is a way of escape, but you got to run. And don't look back. Save yourself and your children. Don't look back. Forget those things that are behind you. God will bless you. Restore everything that you left. Yes, he will restore everything that you leave behind. But run, run, run. Glory be to God. But tonight, Lord, please, Jesus, bless the words that shall come forth out of my mouth, that they will be a blessing to your people, Lord, as we continue this message on what goes up must come down. We're talking about glucose regulation. And tonight we want to focus on treatment. Treat me. Yes. We want to be treated right. We want to be treated appropriately. And if we don't know, how can we make sure that we are getting what we deserve? The right medicine, the right route, the right time, the right dose, the right. Glory be to God. So tonight, let's here we go. Let's put up our little this is our outline for tonight. And I did just want to say really quickly, I'm not going to rehash last week's message, but I wanted to say, that of course we know there's a type 1, type 2 diabetes. Okay. And we talked about alpha and the beta cells that are released in the pancreas. One raises blood sugar, one lowers blood sugar, but the ultimate goal is for our glucose to be normal, stable, and easily regulated, which is not an easy thing to do. It's a learned behavior, especially if you're diabetic. But those of us who are not, we're blessed. All we have to do is eat appropriately, the right foods, the right amount, the right time, and so we have that advantage. And for me, I'm saying we, but for me, as a pre-diabetic, I was blessed to have the same right. And I just had to learn how and what to do to avoid becoming overtly diabetic. And for me, and I really, 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 really hope when I make this statement, you really understand what I mean. We have to not allow our pancreas to burn out. Yes, if you don't put oil in your car and there's a slow leak, and the leak is use over time, a little use, and it trickles, it slowly drops the level, right? And if you don't keep putting oil in there, what happens? Eventually, it burns out. And that is what we do not want the pancreas to do. We eat. The pancreas is working. And eventually, the pancreas says, look, I can't do this anymore. I'm struggling. The liver can't keep up. The pancreas and the liver say enough is enough. And then the pancreas just stops. It just can't do it. And it shuts down. The insulin production ceases. Okay. And there are people who are type 2 diabetics that will not produce enough insulin, and their treatment is if they are a type 1 diabetic. They are totally insulin dependent. Okay, so now we had that little conversation. I'm not going to rehash about the liver and the glucagon that is released from the alpha cells in the pancreas that tells the liver you got this stored up glycogen, and I need you to convert the glycogen to glucose so that the body can have the energy it needs. So GGG, glucagon sends a message to the liver. It's a hormone. It says, you have glycogen stored up and I need glucose. Give it up. Okay. There we go. See, I rehashed last week's message in a nutshell. All right. And so I'm not going to go back and rehash any of that. All right. So tonight I want to talk about the different types of insulins, because many people are put on insulin and they don't understand them the way they really need to understand them until something negative happens. They take the insulin. Oh, shoot, I forgot to take my insulin. Let me go on and take my insulin. And then they don't realize, remember what I said to you last week. If you do not understand the regulation, then you take it too late and don't understand. Well, by the time you took it, the pancreas already sent word, to the liver or whatever. And then you go ahead and take your insulin late, and then you bottom out and can't figure out what's wrong. Okay. So let's talk about the different types of insulin. And then I want to really focus on educating you on GLP-1, the GLP-1s, okay? The new stuff, the new kids on the block, and the mechanism of action of them, and need to know side effects. And I didn't even realize that some people do end up allergic to them. especially Biata. Okay, so let just sit back and relax and let's go, go, go. Let's go. All right, let me see if I've got these in order. I hope I do. Yep. Let me also make this bigger by getting rid of this. And these charts came from Pharmerica. Pharmerica is a drug company, okay? And many times I have had to call Pharmerica to get medicines for my residents in the nursing home. So yes, they do exist, okay? So let's talk about the rapid acting insulins. And I think, let me see, wait a minute. Did I put the other slide in there? No, I didn't. And most people are familiar with rapid acting. We're only focusing on insulins, okay? I'm not going to talk about, the sulfonylureas and things such as that. I don't want to focus on any of those old medications because for the most part, many people, unless you are of an advanced age and you've been on those medications and your doctor says, well, if they're doing fine, I'm not going to take them off. It's not the go-to start drug. Actually, the only drug that most people start with is metformin, okay? And then if you don't do well on when you max out on metformin, they usually go to these newer agents, okay? But people who don't have insulin, or people who, remember we talked about last week, DKA, blood sugar, really, really, really high to the point where your body starts burning fat, okay, for energy because you got all this glucose that can't be transported throughout the body for energy because there's not enough insulin, right? Not enough seats on the bus, not enough buses. All right. So rapid acting insulin, most people remember or they may know Humalog. And actually, Humalog is my go-to whenever the nurse calls me and says, Mr. So-and-so's blood sugar's high, this, that, and the other. And we need to get it down. Like it was their birthday and they ate real birthday cake and they ate 2 pieces and drank a glass of milk. Whoa. All right. So Humalog, and this basically just tells you the generic name. So all of these, what I need you to understand, if you know anything about these insulins that are listed up here, understand they are all rapid acting insulins. And I put this chart up here and I'm going to go through it because I want you to have time to study and see if one of them is something you may know about or take. But Humalog, Admelog, Fiasp, the Novolog, and basically it's, what they're made of. And then you have your Apidra, okay? And they are so sometimes I get a call, the generic name, and the nurse will say, the resident takes insulin aspart and we don't have any. What else can I give them? So then I have to make a decision what to give them. So knowing that this Novolog and the Fiasp are both insulin aspart, I'm like, okay, got it. And the Apidra, we don't do too much of that in the nursing home, but I just want you to see and know that if they're in the same category, they're all rapid acting. So push come to shove, if there's not an allergy and, these are what we would I guess you could say, substitute for, but these are rapid acting. Now, prior use storage. Some people do not store their insulin appropriately. Refrigerate until the expiration date, or you can have it out for up to 28 days. Please remember that. 28 days. All right? And that's all of these rapid actings. So, can you have your insulin out? You're traveling, this, and then you put it in the refrigerator? Of course you can. But understand, you cannot have them out more than 28 days. In use storage. Now this is, wait a minute. Remember, let me back up. Prior to use storage and in use storage. Okay. If you're using it, refrigerate, or same thing, up to 28 days. Okay. But prior to use, most people leave them in the refrigerator until it's time to start a new pen. Now, do you see that some of these say do not refrigerate? Oh, wow. So please. Now, I hate to tell you this, but you know how there's smart people who've been on, I've been diabetic 30 years and they think they know everything. Well, guess what? How about drug companies try to improve their drugs, and they change the formulary or the formulation or how it's manufactured, and they make little teeny changes to the medication, and you been diabetic for 30 years, thought you knew everything and didn't read the label. Oh boy, here we go. And then you wonder, I've been taking my insulin, but I don't know what's wrong, why my blood sugar won't come down, or, okay, just saying. All right, now, when to inject. This is where a lot of people get in trouble. Most of the time, the rapid acting insulin are meal coverage. So people may be on a long acting and a rapid acting, or they may be on a combination, and we'll get there, where there is a combination of a rapid and an intermediate acting, and then they may take a long acting at bedtime. Okay? Yeah. Listen, if you choose to eat what you want to eat, there is a regimen that the doctor can come up with to keep you regulated. It's all up to you. It's whatever you choose. I actually had a patient say to me one time, just give me the insulin. Their comment was, well, can't you just give me insulin? They did not care one iota about their blood sugar being high, because they knew that there was insulin that they could take to fix it. And I said, Lord, please help me get through to them to understand the damage that is being done behind the scenes. It ain't about just give me my insulin. I can always just take the insulin. That ends up backfiring on you when you end up requiring amputations, fingers, toes. Yep. When you lose your sight and you go blind. When you have renal artery disease, lack of blood flow to your kidneys because of your diabetes, and you end up in renal failure on dialysis because diabetes is the number one reason that your kidneys fail. So yes, insulin is available. Oh yes. And there is a regimen that can be created for however you choose to live. But is it worth it? What goes up must come down, even if you personally are what comes down. Come down to a person that used to be able to walk and now is wheelchair dependent. What goes up must come down. You decide. Okay. So when to inject it? Within 15 minutes of eating a meal or within 20 minutes after starting your meal. So AC is before the meal. I'm sorry. And you'll see that on this little graph up here. AC is before a meal and 20 minutes after starting a meal. I tell the nurses, do not give insulin until the tray is right there in their face and they're getting ready to start eating. Now, a good nurse, before giving the insulin, will say, do you feel like eating today? Because a lot of times I get calls because, well, I didn't know Mr. So-and-so had been nauseous all day, hadn't had a bowel movement in 2 or 3 days, and is refusing to eat. You didn't either, but you had already given the insulin. And then you call me and you tell me their blood sugar is 30. So I'm saying this to say, if you're involved in care of someone and you're assisting them to take their insulin, please assess them for their ability to eat. And if the person is taking 40 units, that's because that's a lot of insulin. If they're taking 40 units, this is a person who doesn't even attempt to eat a healthy diet. Okay? So if their appetite's not what it normally is, you say, well, maybe we shouldn't give that much. Or maybe I shouldn't take that much. So you talk to your provider and get a backup plan. And many of them will say, only take this amount if your blood sugar before you eat is this. Or you're going to eat 50% of your meal. Is it that serious? Yes, it's that serious. Is it that technical? Yes, it's that technical. Remember, this is a hormone, a synthetic hormone, because your pancreas cannot do what it needs to do. So when you inject it, you cannot retrieve it. Once it's in, it's in. And so sometimes the nurses get frustrated with me because I go slow. And I tell them why. I'm not going to give this person, because you don't want to call me back in 2 hours and tell me what the repeat blood sugar was. I'm not going to, just for your sake. I ain't got time to be, well, guess what? When you're doing chest compressions and they're coding and you got to call the family and say they died because you gave them too much insulin, okay, then you're going to want to call me back and you're going to want to blame me. And no, we're not doing that. So once it's given, it's given. The only thing you could do afterwards is continuously monitor, start an IV and give sugar through the vein and all this stuff. And remember, we talked about the glucagon injection and all of that, right? Remember, we talked about the glucose tabs and stuff last week. All right. Now, understand the duration of these insulins. Most of them are anywhere from 3 hours to 6 hours. So that is how long the insulin is going to take to be eliminated from the body. It may not peak that long, but it's going to be in the body. All right, so this other additional information about the pen prime, and that's people who are on an insulin pump, okay? Because most of the rapid acting insulins are what are put in the pump, okay? All right, there we go. So that was number one. Now let's go to this one that tells us the difference between we have our rapid, our short acting, intermediate, and our long acting. Okay. So normally, rapid acting is our Lispro. A short acting is the regular insulin. And here's some samples, the brand. NPH is our intermediate acting. And then there's some combinations that'll have like 70-30, which would be like NPH and regular together. Okay. And then you have your long acting, and most people know long acting like Glargine, which is Lantus and Toujeo. Yeah. Okay. So the intermediate, look at that where it says Novolin in and Humulin in. Okay. Understand I've got this up here because I want you to look and see. It may be something that you're familiar with or something you take. So Toujeo and Lantus are both long-acting insulins. All right. Now, I want you to look at the difference because a lot of people take Toujeo and Lantus. Refrigerate until the expiration date or up to 28 days. Isn't it 28 days? 28 days. Keep that in mind, please. 28 days. Now, guess what you're supposed to do? That people, okay, look. If you have something that's long acting and can have a duration of 24 hours, why are you taking it at a different time every day? And then you wonder why you feel bad. Or why your blood sugar regulation why it's so difficult to regulate your blood sugar. It's because you're not taking it at the same time. The key is you have to take your medications the same time of day. So if it's not easy being diabetic, there's nothing easy about diabetes. Nothing. That is the reason why we try to avoid it. Nothing easy about diabetes. Diabetic eye exam, diabetic foot exam, skin exams, you name it. There's nothing easy. They check your urine for protein. All it is. Nothing easy. So the goal is to avoid it. Yes, do you think I'm cray-cray when 10 years ago I started taking medication because I didn't want to become overtly diabetic and I'm still taking it? Yeah. Guess what? There's nothing easy about diabetes and I don't want to be overtly diabetic. I'm going to do what I got to do. Do what I got to do now. All right? So, if I can do it, you can do it. Now, same time every day. There we go. I'm only going to focus on the long acting here because we've got others to cover. But do look at when to inject. It doesn't tell you to inject your long acting before you eat. It just says same time every day. Ding, ding, ding. There's a reason. Okay? All right. Got it. Now, I will make a statement here about metabolites, and how we as individual people metabolize medication. Everybody don't metabolize medicine exactly the same. So do you see where it says 10.8 to greater than 24 hours? It depends on you. We're not all equal. We're probably in the same boat, but we're not exactly alike. Some people are high metabolizers and some people are a little on the low side. And it's how your body breaks medicine down. And I'm not going to get into the technicalities of it, but just know that one size does not fit all. One size does fit most, but not all. Okay? Now, we're going to get even deeper in the long-acting stuff. Here we go. There is a long-acting Dedamer, Degludec, Glargine. Wow. And I think I cut off my screen there. I'm sorry. By enlarging it. But for the most part, you've got your Levemir, your Tresiba, okay, your Basaglar, Semiglee, and your Glargine, okay? These are long-acting as well. They're different long-actings, and they have specifics. But for the most part, refrigerate until it expires or up to 28 days. Once daily at the same time each day. See? All of the long-actings and the durations. Okay? I'm not going to go through each one individually. I just want you to see the difference because we are going to cover the GLP-1s. I really want to get to that. All right. Here we go. Combination insulins. So the reason I'm showing you all these slides, okay, is because there is a vast majority of, there's a vast amount or types of insulins that can be used for diabetes. Unfortunately, some insurance companies won't pay for certain ones. It depends on what's in their formulary. And you may be forced to switch to something else. So I wanted you to be able to see how many of them are similar, just in case. Don't freak out. My insurance won't pay for that. Okay, well then here we go. And you can pull this Pharmerica insulin drug chart up at any time. Okay? And this is not the only one available, but this was the one that I saw I felt that was a little more easier to understand in the way they had them in the chart. 70-30 rapid acting mix. Then you got your short acting mix. Wow. Another rapid acting mix that comes in a 75-25 versus a 70-30. You got your 50-50 rapid acting mix. Wow. Did you even know they had so many varieties and different choices? Listen, I'm telling you, diabetes is so, oh my God. Today, if we had to pick and choose the research and all that going into diabetes management, diabetes would probably be top on the totem pole. You know why? Well, when they figured out, obesity and diabetes, okay? It took them forever to figure out that if you lose weight, you don't have to become overtly diabetic. And diabetes, number one for renal, and everybody, and so many people have renal disease. I'm telling you now, I hate to say it, but there's no reason that for people to I mean, you have to put some work in. Ain't nobody gonna come to you and say, come on now, let's go get your diabetes medicine. If you want to treat your diabetes, you can treat your diabetes. There's a program, there's something to assist you to getting your medication. Even all the $4 plans that they have at the retail pharmacies for you to get your insulin. Okay. So years ago, there were so many uncontrolled diabetics because they couldn't afford the medicine and there wasn't enough medicine. But now today, it does exist. And then recently, when they started paying for GLP-1 for people who were on Medicaid, to God be the glory. We've come a long way. A long, 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 long way. All right, so look at the different, you got your aspart, protamine, your NPH. I'm not going to go through all these. I just wanted you to see them. I've got them listed for you. Don't forget, refrigerate until it expires, or 28 days. Okay, I really hope going through the 28-day thing, ding, 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 to a lot of people listening. Okay. And 28 days does not mean sitting in a hot car in the sun either. Okay? Okay. And then it, of course, tells you within 15 minutes of eating. The same way, anytime you got a rapid insulin and you're going to mix it with an intermediate or short acting, you got to remember to inject within 15 minutes of eating or within 20 minutes of starting your meal. Depends on what you're eating, and it depends on if you're a rapid absorber or not. There's your durations. Okay. All right. Now, I want to move on to our GLP-1 because this is the new kid on the block. This is what's hot, hot, and heavy. And this is where I really, really want to spend more time. But before I do the GLP-1s, I got to address this next slide that I created. Now, this is according to the NIH, National Institute of Health, okay? In regards to the different types of diabetes, I want you to see and know the classifications of the different diabetes and what they're using and what the abbreviations are. So remember now, type 1 or juvenile diabetes, they still call it that. Pancreatic beta cells. Remember, I told you that the betas secrete the insulin, and the alpha, the glucagon. So the pancreatic beta cells are destroyed by the body's immune. Oh, are you serious? Yes. The body's immune system, or trauma or injury to the pancreas. Remember when I said about people who have pancreatic cancer, or people who had gotten a car accident and their pancreas, was damaged or whatever, and then they end up being type 1 diabetic, okay? Leading to decreased or absent insulin production. All right, and they will always require insulin. This is just me to rehash the different types of diabetes before we move on to the GLP-1s. Type 2, most common type of diabetes, and usually occurs after the age of 45. However, children and teens are also developing it more frequently. Tell me why. Tell me why. Come on now. Obesity. Obesity in children and teens. Why are children now becoming more type 2 diabetic? It's obesity. Oh, I didn't even finish reading it. They're developing it more frequently, mainly due to childhood obesity. Oh well. I gave the cat out. I gave it out before I even read it. In type 2 diabetes, cells are resistant to the action of insulin. The exact cause of this is unknown, but factors such as genetics, obesity, metabolic syndrome. What is metabolic syndrome? We talked about that before. Metabolic syndrome has a lot to do with a person's abdominal girth. I'm not going to get deep into it, but just know that if you have an obese abdomen, it puts you at risk for metabolic syndrome. And part of metabolic syndrome is cholesterol. Okay? Or a sedentary lifestyle to play a role. As the pancreas secretes more insulin to try to get glucose into the cells, they eventually do what? Ding, 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 burn out. And glucose starts building up in the blood. Treatment with insulin is necessary for the later stages of type 2 diabetes. You have no choice. All right. Then there's two more types. See, most people know type 1, type 2, and that's the reason why I wanted to present this here. There is a maturity onset diabetes of young. Is an inherited condition in which the beta cells of the pancreas cannot secrete insulin due to a genetic mutation. Patients are younger, healthy weight. What? These are the children who are diabetic, young teens who are diabetic that have never been obese a day in their life. And I truly believe that my father actually fell into this, even though he was 29 when he was diagnosed, but he was never obese. He was 29. And it says without antibodies for the islet cells of the pancreas and have a first degree relative with a similar type of diabetes. So we don't know for sure, but I know his mom was diabetic and he developed diabetes at 29. He either was a maturity onset or he probably developed some type of viral illness that attacked his pancreas. But he did produce some insulin, just not enough. And he's been on insulin ever since he was 29. So insulin or sulfonylureas are treatment options, okay? But the sulfonylurea alone is usually not going to be enough. The last is gestational diabetes. Approximately 4% of all pregnancies in the U.S. are complicated by gestational diabetes. Screening for diabetes is performed during the 24 to the 28 weeks of pregnancy. An initial treatment is with diet and exercise. Treatment is necessary to prevent complications of preeclampsia, macrosomia, and shoulder dystocia. And these are things that happen to the baby. When diet and exercise fail to control the blood sugar level, insulin is indicated. So I will say, I remember I passed my glucose tolerance test when I was pregnant with my middle child, but I ended up having a large for gestational age baby. And they said, well, you must have become gestational diabetic at the end of your pregnancy. Oh, okay. So the gestational diabetes, the family history is, and altogether was one of the reasons I was very aggressive in identifying prediabetes because of all the other risk factors. And then I also learned that because I was premature, that increases my potential for being type 2 diabetic as well. So I was like, dang, what else is stacked up against me? But it's okay, because years ago, they didn't know all of this stuff. All right, now, let's talk about the GLPs. All right. Where do I want to go? Got to figure out if I got my slides in order. The GLP, here we go. GLP-1. Let's talk about what a GLP-1 is. A GLP-1 is a hormone that your small intestine makes, your colon makes. It has several roles, including it triggers insulin release from your pancreas. Are you telling me that my intestine can also affect insulin production? Yeah. Maybe not as much as your pancreas and your liver, but insulin is an essential hormone that allows your body to use the food you eat for energy. It lowers the amount of glucose in your blood. If you don't have enough insulin, your blood sugar increases, leading to diabetes, blah, blah, blah. Blocking glucagon secretion. Okay. Glucagon is a hormone your body uses to raise your blood sugar. We already talked about this when necessary. So the GLP-1 prevents more glucose from going into your bloodstream. Follow me, because I need you to understand these things when we talk about those new drugs, the GLP-1s. GLP-1 also slowing stomach emptying. Slower digestion means that your body releases less glucose from the food you eat into your bloodstream. Okay. Wow. Now, let's talk about, let me see if this is the next slide I want to use. No, that's not the one. And I do apologize. I think I made these slides too big. GLP-1 agonist medications are currently available in the U.S. market. These are the GLP-1s. Now, exenatide is an older one. Okay. There's the Byetta. That was the first one I ever heard of. Then I remember the liraglutide Victoza. Then I remember, wait a minute, I'm sorry. After Byetta, I remember the extended release Byetta. Okay. And then the dulaglutide, which is Trulicity, dulaglutide, excuse me. And then I don't remember anything about Adlixin. But then, of course, we know that there's a semaglutide, which is the Ozempic. And then we had the semaglutide tablets, Rybelsus. And then we're going to talk about the Wegovy and Mounjaro and all of that. Okay. And so these are a similar class of medications called dual GLP-1 GIP receptor. That's what the Mounjaro is. I'm trying not to make this complicated. So let me go to, here we go. Let's explain this right here. The difference. Exenatide, which is the Byetta, you had to take twice a day. A lot of people didn't want to take that twice a day. So it lost its popularity when the newer things came along. Then they came up with an exenatide extended release, which was the Bydureon, which was once a week. Okay, we're making progress. And so then we come up with the medications that we took once a day, like Victoza. And then we come up with our Ozempic and things that we took once a week. So the reason I put all these up there, I don't want to go through each one and try to say this is this one's better than that one. I just wanted you to know that the advantage and disadvantage, they basically all function the same, is number one, are you willing to take an injection twice a day, once a week, or what? And guess what? Sad thing is, will your insurance pay for it? Okay? They're not cheap, and it depends on what your insurance will pay for. Bottom line, can you control your insurance? Well, it depends on where you work. And then wherever you work, they can choose to switch insurance. So you need to know enough about these medications to know that there's alternatives and understand the differences, the potential differences. Okay. I do want to mention this because I did not realize that exenatide, it says that you can have an allergic reaction, and I do apologize because I think it cut it off. And let me see. I don't know if I can. Let me see if I can fix this slide. Hold on a minute. Let's see. Yeah, I can. There we go. Thank you. Thank you, Lord. Here we go. There we go. I fixed it. GLP-1 agonists and allergic reactions. Some people form antibodies. Remember what I said to you about the immune system and woo, Lord, 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 Lord. Father, I thank you for immunity. But you don't never know when your body is going to fight against something. So guess what you do? You pray, you pray, you pray, you pray, you pray. Keep yourself anointed and you pray. Okay? Pray over your medicines. Remember me telling you that? I said, don't take any medicine you didn't pray over. And not that you pray over it every time you take it. But when you get a new prescription, this is what I do. I try to. You get a new prescription, you get ready to start a new medication. Pray over that medication. Lord, let it bless me and do me no harm. Father, what it is intended to do to help me, take care of me, to preserve me for your use, God, not for your personal gain, not so that you could party and get, whatever all the time and not go to church and give God glory and not praise him. I didn't say not have a good time. Have a good time. Enjoy life. But give him what he deserves. Okay? But pray over the medication. But some people develop antibodies to the GLP-1s, particularly with exenatide. Now, I told you what exenatide was. That's Byetta. And then Bidurion is the long extended release one. This can cause issues. Well, let me tell you also, I wonder why they can say that now. That's one of the oldest drugs. We don't know 5 years from now how these newer ones will do we? Okay? This can cause issues with the effectiveness of the medication, but it can also cause allergic reactions at the injection site and potentially anaphylaxis, which is a severe allergic reaction. If you notice persistent itching, redness, or other symptoms of an allergic reaction at injection sites, talk to your healthcare provider. Now, I will say this. Your injection site, how about clean it with alcohol? Let it dry. First of all, before you even clean it with alcohol, what you should do, take a bath. Bathe your body. Wash all the microbiomes and things that don't need to be there off. Okay? All right. Okay. Take a good bath. Clean yourself well. And clean with alcohol. And then inject. And pray. All right. And this just tells you symptoms of anaphylaxis: shortness of breath, wheezing, hives, difficulty swallowing, red rash, chest tightness, abdominal belly pain. Okay. All right. I'm trying this. There was one other slide I think I messed up, but let me see. Let me see if you can read this one. No, yeah, we already went over that one. The last thing. Yeah, let's go over this one. And I'm going to edit this slide and fix it so that, there we go. So we can read the whole thing. I'm sorry. There we go. So GLP-1 agonist medications work, because I wanted you to tell you specifically how it works. it mimics mimicking this hormone. In medication terms, an agonist is a manufactured substance that attaches to a cell receptor and causes the same action as a naturally occurring substance. In other words, GLP-1 medications bind to GLP receptors to trigger the effects or roles, the GLP-1 hormone. So remember the hormone that I told you that our small intestine makes? Okay. So this is how the medication itself works. And so they learn how to make this hormone that is in your GI tract, right? So we have combinations of stuff, right? We have insulin that mimics the insulin that our pancreas makes, right? And push come to shove, if we need glucagon, we can give ourselves an injection of glucagon, right? God is so good. He allowed man. Man didn't allow him, okay? He allowed man to learn how to make these things that our body needed for glucose regulation, okay? And so he allowed man to learn how to make the hormone that your small intestine made. Because is it not our small intestine also that help with digestion of the food and all of that and weight loss? And come on now. Think about it. That's why the GLP-1s are so effective. You know, early satiety, make you feel full faster, right? All those things, delayed gastric emptying, all those things. Make you more sensitive to the insulin that's being produced. Because there are some people who are on GLP-1s and insulin. If you can tolerate them, everyone cannot tolerate them. All right, so it says, in other words, GLP-1 medications bind to GLP receptors to trigger the effects or roles of the GLP-1 hormone. The higher the dose of the GLP-1 agonist, the more extreme the effects. So that's why you could take the same drug for diabetes, give it as a higher dose. For example, you have your Wegovy and you have your Mounjaro. They're the same drug, but one is at a higher dose for you to lose weight. The other is for diabetes at a lower dose. It's indicated, same drug, same exact drug. They just changed the name, right? To show the FDA approval, because FDA will only approve it under a certain name for a certain indication. So the drug is approved as Mounjaro for diabetes, but then it's approved as Wegovy for weight loss, but at a higher dose. All right. Okay, I'm just using that as an example. That's one example. But Ozempic and Victoza is the same thing too, semaglutide, right? So you can take Ozempic, the same drug as, oh shoot, wait a minute. I might be mixing them up. Oh Lord, I got them. Hold on. Let me go back to this so I won't jack you guys up. Ozempic and Rybelsus is the pill form. Hold on. But regardless, the deal is this. They're the same drug, but one at a higher dose. I want to tell you right, so let me pull it up. Sometimes I get I talk too fast. And yeah, Wegovy, is semaglutide. Wegovy and Ozempic are the same thing. Okay? Please forgive me. All right. Now, Manjaro is Zepbound. Whoo, Jesus, help my Father, help my Father. Manjaro and Zepbound are the same thing, and Wegovy and Ozempic are the same thing. Whoo, Lord. But guess what I do? I don't even trust myself. I check and double check. I tell the nurses when they call me, I say, hold on a minute. Let me check behind me. I know what I know. But sometimes so much going on in your head, it's easy to, that's where, sound alike, whatever. There's so many that you have to go back and say, wait, hold on. Okay. I remember when I switched from Victoza, that's right. Victoza was daily, and I got tired of taking Victoza daily, and I switched to Ozempic. I was trying to remember. So whatever I said earlier, if I mixed up Victoza and Ozempic, they are not the same exact drug, but they both were used to treat diabetes. One was, the formulary was daily, and I wanted to go to weekly. So then I went to that. All right, now, move on. The last thing I wanted to tell you was there is a difference. I wanted you to understand a GLP-1 and a GLP-1 receptor agonist. I wanted you to understand actually what Manjaro was. Why Manjaro, tirzepatide, right, which is Zepbound, has been more effective for weight loss than some of the other GLP-1s. I'm not saying it's a better drug now, but it has had significantly more weight loss, okay? And it's because it is a combination of two GLPs. It is a GIP, which is a glucose-dependent insulinotropic polypeptide, and a GLP-1, glucagon-like peptide. What? Just hear me out. They are both incretin hormones. So incretin is GI, right? The gut stuff that stimulate insulin secretion to regulate blood sugar, but they differ significantly in their actions on appetite and metabolism. GLP-1 potentially reduces appetite and slows gastric emptying, right? Making it effective for weight loss. So you've got the GLP-1 slows the gastric emptying and making it effective for weight loss, while you also have a second component in the medication, which is the GIP part of it that focuses more on fat metabolism and insulin sensitivity. That is the advantage of the newer co-agonists. It's two types of medicines in one, like tirzepatide, which is Manjaro, or Zepbound, because it offers superior weight loss benefits by combining both. That is the new kid on the block. So here it is. It's the GIP. It works on fat storage, glucose uptake, insulin secretion, the survival of the beta cell, glucagon secretion, okay? Gastric effect, the gastrin secretions, gastric acid secretions are decreased. Bone effects, bone formation, osteoclastic activity. We don't want to, bone turnover, basically. Okay, it decreases bone turnover. So if you're, Anyway, it does a lot of stuff, but how much does it do to like, for example, if a person with osteoporosis, so you could take one drug and treat so many different things with one drug. But is it significant to treat a certain disease entity? Not necessarily, no. Because I'm not going to say that the increased bone formation and decreased osteoclastic activity is going to treat your osteoporosis. I can't say that. Okay? All right. So, there we have it. I pray. Let me see. Yep, I did cover that one. All right. I think we did enough. All right. So, I hope I didn't confuse anyone. I hope I gave you additional information that will help you. This is our part 2. What goes up must come down. Understanding what's out there and what's available. Not a one size fits all, but a one size can fit most. Okay. There is a diabetic treatment regimen available for each and every individual. The issue is, number 1, you must be honest with your doctor. Don't tell them, the proof is in the pudding when they check your hemoglobin A1C. Don't say, I'm taking my insulin. Are you taking it like you're supposed to? Are you taking it at the same time every day? If it's a long acting, are you taking it before the meal like you're supposed to? Huh? Or are you taking it too late after and then you get the spike in your blood sugar from when you ate because you didn't take it like you were supposed to avoid the spike? Are you taking them like you're supposed to? Be honest and say, I don't take it like I'm supposed to. Because what they do is they keep adding more and adding more and adding more. And when they add more, what happens to you? You bottom out. That's not good. Okay? So I'm just telling you that you have to be honest. Do attempt to cut back on your carbs. I already told you about the keto. Look, keto diet, I don't promote because you got to have some carbs to live. But can you take advantage of keto bread? Especially if you're a bread eater. Yeah. Take advantage of the high fiber bread. That's what makes it keto silly. Is nothing that they've done like synthetic something to it. No, they added more fiber to. Okay, so the keto bread, instead of being made with regular wheat flour or whatever, they make it with almond flour, and I think it was, they use coconut and almond. They use other forms of flour, different types of flour to make it. And it's higher in fiber. So they cut back on the bad stuff, give you more of the good stuff, and made it into a bread. That's why it costs more. But guess what? It tastes good. I've enjoyed it. And it helps me when I eat a sandwich to have a bread that is ketogenic. Okay? All right. Enough be said. I'm done. All right. Well, listen. God bless each and every one of you. This is my weekend to work. So, I'll see you all prayerfully. If it's God's will, I'll see you on next week. To God be the glory. All right. Praise him. Praise him. I pray that you have a restful night's sleep. Please like and share, and help bless someone. Not me. I'm just an empty vessel. Not me. Please don't do it for me. I can't bless you. God can, okay? But share the material so that others can be blessed, okay? Feel free, all right? I know I have a supportive cousin. I have a supportive family. To God be the glory. I love my family. And I know my cousin, she will share my broadcast because she knows there's people who need to hear what's being said. All right. God bless. Good night.
Thank you for watching SHEM Ministries.